Should I just start, John? Or wait? Okay, we're gonna start back again. Is it on? Is that going? All right. So good afternoon. I am part of the board of directors for the Health Data Coalition. Some of you have saw the booth outside. David Chan, who's standing in the back, is one of the who's manning it, and we have Kent over there sitting down, and we have Varun, a data analyst in the corner there. That's part of my team. We're going to talk about quality improvement and PCN, the primary care network planning, today. First off, I want to say I've gained so much from this community. This is the photo on the OSCAR Galaxy website. I'm honored to be there on the bottom right there in the blue. I've gotten so much benefit and so many efficiencies from stealing all of your e-forms. I want to thank you so much for that. John Yap, David Page, etc. I've gotten so much benefit from you. Thank you. Thank you so much. This is the quality improvement model that we use from where I was trained. It's called the Model for Improvement. 3 questions. What are we trying to accomplish in this particular improvement project? How will we know it's an improvement? And what changes can we try to see if we can make an improvement? Logical, pretty simple. And then we do some PDSA cycles, some trials, some predictions of changes, and we see what impact it might have. Primary care networks are a big change idea for British Columbia. We're trying to network different patient medical homes, different clinics run by physicians, run by the health authority, run by nurse practitioners. And we're trying to see if we can improve access to care, if we can extend hours so that patients can get more access after hours, so that through the collaboration and the synergy of different providers coming together, we can actually provide increased quality of care access to the patients. The Health Data Coalition I joined last year as a board member is about improving data metrics in primary care, improving our access to those metrics. This is how we're funded. We're funded through the Doctors of BC. What's the Doctors of BC equivalent in Ontario for those from Ontario? OMA, Ontario Medical Association, yeah. Doctors of BC used to be called BC Medical Association. So we have the Practice Support Program, which is under that same funder. They help us to do quality improvement projects. They have coaches that will come out to different practices and try to help you design things to improve your care. The FPSC is a governance body that's kind of like makes big decisions about which projects we're going to fund and which we won't. Divisions of Family Practice is an innovation kind of borrowed from New Zealand, where we recognize that every neighborhood needs a hub of family medicine leadership. I understand that in Ontario there's the concept of FOES. I was talking with Edwin earlier about FOES, which is Family Health Organization. And so the primary care networks are kind of like that. And the Divisions of Family Practice's job is to try to shift culture such that family doctors actually get together with nurse practitioners and get together with allied health to build kind of one-stop shops for patients. The Health Data Coalition is a data steward for that, all that work. Health Data Coalition is created by family physicians and is led by family physicians. This is Dr. Bill Clifford and Dr. Shirley Z, who are well known in our province for leading innovations like this. The governance of the Health Data Coalition, each of these little networks, it represents one of those neighborhood divisions of family practice. And there's 35 in the province of British Columbia, 35 divisions of family practice neighborhoods. And from there, we source 11 board members. The board member, 11-person board member, also includes 2 specialists, 1 or 2 specialist physicians to assist us with that perspective, and also non-clinician patient partner voices. We have 13 operational team members and some contractors. 3 of them are in the room today. The Health Data Coalition takes data and anonymizes it. It takes it from the OSCAR EMR, it takes it from Wolf, IntraHealth, It does not yet work with Accuro Juno and TELUS CHR, but potentially those are in the works for the future. But right now we have quite a few different EMR data sources that we pull from to generate excellent data visualizations. So we have this rule called the rule of 5, which kind of guards your vulnerability, your data vulnerability. If you're kind of nervous about sharing your data, we kind of use that number of 5 sharers before we actually share or display any data on the system. And you also choose, as the person, as the physician or the nurse practitioner, whether or not you want to share at all. You can just have the viewer, the data visualization for yourself. That's also how many people are using it, just so that you can see from a population of your clinic's level how your clinic is doing on different metrics. This is that example of what OSCAR currently, OSCAR 15, has its own data visualizations. It has a pie chart. Maybe this is the hypertension prevalence pie chart. HDC Discover platform, that's the name of the data visualization software that we have. It does run charts or data over time for metrics, because your quality shifts from month to month, from week to week. Quality improvement is a continuous sport. It's a continuous quality improvement effort. And so every moment, your quality could be different. So data over time is actually the preferred way of looking and monitoring quality. Each of these colored lines here represents a different geographic area in the province, and we have many data contributors that make up each of these data points. So they're summarized, they're summed into there. So no, you can't identify which particular clinic these came from, but you can identify the general geographic area. And that can give you a really powerful data set, a really powerful understanding of some approximations of what the reality is in each neighborhood. We have 5 different health authorities, which are geographic areas that our health ministry has divided British Columbia into. We're currently in Vancouver Coastal Health, and in this region we have 246 data contributors. So 246 physicians or nurse practitioners have signed up to give anonymized aggregated data into our system so that we can use it for visualization if they allow us to. In Fraser Health, where I'm from Surrey, British Columbia, there's 265 contributors, for example. And we're still looking for more. Any of my team members in the back, do you remember in total how many data contributors we have? I know it was just math here, but it's about maybe 1,500 to 2,000, somewhere.
About 45% of the province.
Okay, we have 45% of the possible data contributors. So we're still the minority. We really encourage more people to offer their data for that. Me as a primary care physician, I was raised like this, as a people pleaser. I didn't really have great boundaries starting out and working. I see a lot of resonance in the people in the crowd. So some of you may have read about my article from Doctors of BC about my own struggles with anxiety and how I was really drawn to a lot of patients, to take care of patients with mental health challenges. And part of that was I really didn't understand how to offload the emotions that I was facing day to day as a family practitioner. So for me, technically, I'm quite technically adept, but when it came to emotional management, I was not skilled, not understanding the emotional boundaries and energetic boundaries. And I'd chosen to go to a practice that served a lot of people with low socioeconomic challenges. This is this was for an article from the Surrey Now newspaper. A lot of my patients living in tents in the parking lot of my clinic. John's been to my clinic before. John, you know how that interesting neighborhood. Yeah, it's always interesting. You wonder if all your car's parts will be there when you're leaving. And I felt bad about that. I was managing patients as well as managing the parking lot. And eventually the parking lot management became like maybe a bit higher priority than managing my patients. So I easily burnt out. I burnt out really quick, maybe 5 years into my career. I'm now 13 years in, but 5 years in, I was burnt out really bad. And I actually internalized a lot of the stresses that I was dealing with in my practice. And this is a screenshot from from OSCAR of my own CRP. My CRP level was 45.3, and I had no infections. And those of you who know what a C-reactive protein means, this is a very significant level. So my inflammatory system, those of you who are fans of Dr. Gabor Mate will understand the neuroimmunological, the psychoneuroimmunological system. And I was living through that and learning through that. So I had to learn about boundaries so that I could take myself out of those intense one-to-one visits with the patient and figure out how can I, on a systems level, really improve how I'm doing as a physician, and how can I maybe make an impact on the system as a whole. And I had to really learn that when I said yes to my patients, when I was saying yes to my staff, to my colleagues covering their shifts at the hospital per se, I had to make sure that I wasn't saying no to myself. I also was very much in the passive side. I was taught to be obedient, to say yes, to be a people pleaser. And I was really in that passive, sometimes I'll lose and that's okay and you win. I had to shift a lot of my behavior into the more assertive position, trying to find win-wins. So making sure I wasn't working harder than my patients for their wellness. Ensuring and understanding that the capability for wellness exists in the patient's hands and not in my own. I learned this from Prentice Hemphill. He said that boundaries are the distance at which I can love you and I can love me simultaneously. That was really powerful for me because I was raised in a culture where we're supposed to love, and love with maybe unconditional regard sometimes, unconditional positive regard, and that is not really possible as a human. So learning about this human boundary, this human limitation, really helped my journey. When I was deep in burnout, actually with those inflammatory processes, I had dactylitis, enthesitis, I had trouble walking. There was points when I would be hobbling through the clinic with a walker, still seeing my patients. And I know many of you have gone to work ill and sick because you care so much. I met Dr. Don Berwick at the Institute of Healthcare Improvement in Boston. I was sent there because I actually went to the CEO of my health authority and I said, the quality of the care that we're providing is garbage. And they're like, okay, we can fund you, you're lucky, we'll fund you to go get some training to how we can improve healthcare. So this is in Boston. I did the QI coaching certificate there, and I ended up doing the Join Work certificate there. I ended up doing the QI advisor training there. I brought back the stuff that I knew and some other clinicians. This is my colleague, Rebecca Adams, who's an ER doctor in Langley Hospital. And her and myself and a bunch of colleagues, we started to teach quality improvement methodology, data visualization understanding to our colleagues in Fraser Health. We would hold them over Zoom. This is a Zoom example. We would talk about data analysis. We started to partner with patient partners. So those two over there, Pam and Sandy, are patient partners. We have a cardiologist in the back of the van. We have a business specialist there, Aman, and we have family doctors in there. We realized that QI is a team sport, and when we work together, we do better. Part of my training was from Dr. Kurt Smetcher, who's an anesthesiologist out in Abbotsford, and he was teaching us about data science. And one of his teachings, you can see there's a normal distribution there. And if you turn a normal distribution on the side, such that the phenomenon that you're seeing is on the y-axis, and then you expand it over time, you get data over time. If you wanted to collapse all the data points from the right and stack them on top of each other, you can get back to this sideways normal distribution. So that's how we're actually looking at data. And variations, when data varies from the normal distribution, that's a sign that your system is changing. And that's what we go for when we're talking about data shifts, data improvement. We're improving our system when the data shifts from that usual distribution of data. One of the main points in quality improvement, the main aims, is called the quintuple aim. And that's about improving population health, improving patient experiences, improving care team experiences, advancing health equity, and being great stewards of our resources. So these 5 aims simultaneously can really guide us to a more sustainable health system. And every QI project touches one or more of these areas. That's called the quintuple aim. When we look for shifts, like I said, from the normal distribution, we'll be able to identify that our system has improved or changed. And often we're just looking at different trends. The data is trending in the right direction. The A1Cs are coming down. The COPD rates are as expected. The FEV ones that we've documented in the chart for all the lung function tests are in place, for example. As part of the quintuple aim, we talk a lot about advancing health equity now. And what that means is really understanding how do people, understanding how are people actually becoming healthier? And we actually understand that access to healthcare is only 10% of why people get healthier. Genetics and epigenetics, environment is about 40%. And then 50% are healthy behaviors, self-care behaviors, connecting with nature, eating well, being active, socializing. So this is science. We know this. But what are we spending our funding on in our system? We're spending so much funding. I think we're projected to spend about $27 billion in British Columbia in next year on healthcare. We're spending so much in medical services when medical services are 10% of the problem. We're spending 88% of our budget. This information is from Boston too. It's from Massachusetts. Healthy behaviors, we're spending about 4% of our budget, and other 8%. But we know that 50% is from healthy behaviors. We're spending a lot downstream, guys. This is the per capita spending projected from 2022. We have Quebec here at $8,700 per capita for healthcare spending. British Columbia is about $8,700, so really similar. Ontario, $8,200. So we're spending quite a lot. Each one of us has that price tag on us. That spending is going into the system. And what are we basing those decisions on? A lot of those decisions are based on who's the loudest, who's the squeakiest wheel, yeah? When we get back to what are we trying to accomplish, many of us are trying to do different things in the health system. What change can we make that might result in improvement? And that's where that innovation that we've been talking about today is. How will we know that change is an improvement? The second question, that's where Health Data Coalition comes in. In quality improvement, we decide on what we're doing, which is our aim. We try to figure out what are the contingencies that build to that aim. And then we have change ideas. So the Health Data Coalition, again, shows us whether or not we're making a change in our improvement. This is a view from the Health Data Coalition. The green line represents over 3 million different data points. Myself, I'm pink in this one, and then one of my friends is blue. I didn't ask for permission, so I just put them my friend. As you can see, this allows me to reflect how I'm doing on a particular metric, comparing myself with maybe the provincial average, or comparing myself with my friend. We have a concept of gamification. I'm gonna do better on my A1C reduction than you are in my clinic, for example. This is an example of a disease prevalence metric, the percentage of my patients with heart failure that's been documented. This is an example of documentation quality. As you guys know, many of us in the pandemic started to try to get more emails into the chart. So this is a measure, how many emails are in the chart? I started out pink, about 15%, and I ended up in current day about 60%. So, and everybody did the same. You can kind of see some of those trends. This is a disease management metric. This is the percentage of cases of diabetes with an A1C tested for and documented in the chart in the past 6 months. This is diabetics with normal range blood pressures. So are we managing our diabetics well enough? Are we making sure that we're controlling the blood pressure? This one's about patients with schizophrenia and with a visit within the last month. Have we actually engaged them? The pandemic has been a really hard, isolating time for a lot of people with mental health challenges. Have I called them in? And so in Q2 of 2023, you can see that's probably where I realized, hey, I haven't called them in a while. And then the pink line goes up because I made a difference there. This one's about medication prescribing, benzodiazepines. And there's been a lot of fluctuations as guidelines change, as awareness of the low efficacy of long-term benefits with benzodiazepines. So people have been deprescribing. And so those are some of the applications for the data within HDC. You can do deprescribing projects. This one is percentage of patients with their cervical screening completed. So you can see here in quarter 2022, again, due to probably the pandemic measures, I was not screening as much over those years, and then I decided, and then the pink line goes up. Many of you in British Columbia have heard about my city, Surrey, and how there's been crises everywhere. And so many of these crises are because of stark funding disparities. Because where does the money go? The money goes to where people are most proximate to. And if the decision makers are maybe here in Vancouver downtown, this is where the money potentially will go. Because there is no real data infrastructure to tell the system where are the needs the greatest. Yeah? And Health Data Coalition plays a role in actually allowing people to see where some of those disparities are ahead of time, proactively. And with the application of technologies that we've discussed earlier today, we may be able to get ahead of it. We may be able to be predictive with machine learning and et cetera going forward. As a result of our squeaky wheel, we're finally in Surrey, we're getting the ministries finally coming and doing some stuff. But imagine if we could do this ahead of time. My city must receive its fair share. You know, that's that sense of inequity within our system, and it's because there is no data infrastructure. The primary care networks that we discussed earlier today, right now we're about 40%. So each one of these patient medical homes is contributing data, the ones that have the graphs on them. And at my divisions of family practice, which is those neighborhood level leadership groups, we're starting to have access to look at some of the data that each contributor allowed us to look at. If they don't allow us to, we can't see it. And there must be an anonymization. All the data is delinked from patient charts. And then we can actually start to fund the gaps in our system to address some of those. Sometimes it'll be in the social determinants of health. With all the different building blocks that really build up healthier communities. Things like mental health services, income security, housing security, food security. What other data sensor do we have in our communities other than primary care centers, other than your clinics? You guys have some of the greatest information that could help our communities. But if it's locked into a silo, we're missing opportunities to benefit the whole. And again, Health Data Coalition, I'm a big fan of them because they are physician-led, and it's not, thus far, it's not beholden to any corporate or special interest at this time. So this is a reminder that we need to be focusing on the right problems. This again is from Massachusetts research. Imagine if we could have a data-informed community resourcing. That would be amazing. And this is my future state where every patient medical home is contributing data that's delinked and anonymized. I want to give you a few examples as I close. This is the prevalence of chronic pain in that patient population that I had showed you about. About 25% of my patients actually have chronic pain. It's a very high. And this is that driver diagram with the aim. I want to maybe increase my brief pain inventory usage. And I actually coincidentally worked with John with the PSP program to develop pain e-forms. And so some of my change ideas were to use the OSCAR e-forms. In my primary care network, one of our change ideas was to leverage social workers. Let's advocate for the ministry and the PCN to give us more social workers to use in our environment. And we actually created an e-form for in OSCAR for the PCN social workers. That's what we called it, the Surrey North Delta Primary Care Network's social worker referral form. So there was some great impact there. This is an example of one of the metrics about, are we having the A1Cs at least below 7.1%? And this is from my colleague, another board member, Dr. Omesh from up north. And you can see over time, his is the blue line, he increased his percentage compared to the average comparators of patients in range with A1C in range. And the quote from him was, after doing the complex care visits for the patients that he identified using the HDC Discover platform, it was really neat to see the reduction in A1C so easily on the graph. You could really see and validate the work that was being done. This is an example of actually a primary care network where they brought a nurse in as a change idea. So you can see in the pink line, the number of patients who were actually screened for their A1C test jumped up from 20% to about 80%. That's a significant jump. And this was attributed to the nurse coming into practice, team-based working on this. And the nurse's response was, she became actually tearful when she saw her impact because on this metric. She said, I can't wait to go home and tell my husband what I've been working so hard on, that I've been able to prevent cardiovascular disease advancement in my population. I thought that was beautiful. I'm going to take some questions here, but please consider, if you're not already contributing data, email info@hdcbc.ca to learn more, or just to ask questions. Feel free to. And again, we have Kent and David and Arun in the back here for any questions. This is my private quality improvement, not private, it's open source. It's an open source quality improvement community. People just share different ideas about quality improvement. It's a WhatsApp chat community. It's not related to HDC, but I'm up here and I thought I'd share it anyways. Thank you. And any questions? I saw a hand up, yeah.
I'm just curious, is this the database that PSP is using when they're doing their work, or is that a completely separate?
PSP has a lot of help in doing some of that panel cleaning up panels. That means like getting demographics right, ensuring the active patients are actually active patients in OSCAR. And then they will assist the physicians to sign on to HDC. Yeah. I forgot to mention Dr. Herb Jang is also available for questions on HDC as well. Yes?
What's the Health Data Coalition's relationship with the Community Data Program and with the Canadian Institute for Health Information?
Currently, I think we might be just like friends or buddies, but we don't exchange data with them at this time. The data right now is at the level where it's for each provider to review, and if they allow their division to review their data, that's it. So in terms of data sharing, we're just within the physician community right now, physician and nurse practitioner community. We don't have any official or data sharing agreements with those people yet. Yes.
When you are looking at the data, is the clinic able to kind of pick what data points that they want to look at, or do you have a preset formula?
So there are 185 different metrics on the system. And some of those categories which we discussed today were around disease prevalence, screening measures, disease management metrics, documentation quality metrics. Those are the ones that come to mind. We do have some plans for additional areas for quality improvement, but we haven't fully developed them yet. Any other comments or questions?
How far
Yes,
back
John.
can you go with the data to see
Yeah, so the HDC started in 2016, so we're only 7 years young. Most data collection from contributors was probably around 2018, so 2 years in. So that's as far back as we can go right now, 2018. That's 5 years. Yeah. And you can look at the data on different scales so that you can actually see the impact of different changes.
How does, for instance, in one clinic, inconsistency between how different doctors record things in their EMR impact the
Yeah.
accuracy of that data?
Yeah, so the question was, if you put garbage into the EMR, you're just going to get garbage out, right? And that's correct. So the practice support program is a great partner for us, and they assist clinicians and medical office assistants to improve the way that they're documenting, such that it actually goes into the right buckets and it doesn't reflect erroneous stuff. And we have filters on the software to try to reduce that too.
In that perspective, that's actually a great QI project for a clinic if they're on. Is just to say, well, we have not been labeling our patients very well. You can sort of think, one label is that this person's COPD, and all of a sudden you see your numbers, client, you see that exactly those kind of skills. That is your QI project, right? You say, well, I'm just doing a cleanup. Yeah, that's a QI project.
Yeah, for those who couldn't hear, Dr. Herb Chang said it's a great opportunity for a QI project to improve documentation practices. Yes?
Like on the side of the providers, like for them to spend all that extra time like labeling, it's like a lot of work. Like is there anything you have in like assisting to make it easier?
Yeah, so the question was, how do we help the care teams to actually document better? Because it's a tedious job to do it. So the practice support program often offers a little bit of funding to assist with new practice development, like how to actually document things correctly. And then it becomes a habit going forward. So there's like the historical cleanup, and then there's the good habits going forward. Yeah. Yes.
What is the risk of sharing the data with you? Is there any chance that government could subpoena records about an individual physician? Because you're collecting data on individual physicians.
Yes, we're collecting data that's de-anonymized, unlinked to patients. So the question was, can the government subpoena data from your database that's anonymized? I'm not certain how to answer that. It's not happened yet that the government has demanded that we hand over any data. That has not happened. Dr. Herb Chang, can you help me? No.
I think that's a valid concern because the government can do anything, but I would then reflect back, what's to stop them from just subpoenaing your OSP?
Because Bill 36 is going to be introduced.
Mm.
And that allows government to walk into your office without any subpoena and obtain your medical records.
Mhm.
They already have your teleplan data anyways. They already have your teleplan data anyways. And that's not anonymized.
Mhm. So the response for those who didn't hear is that the government already has your billing data, and it would get higher, it would get linked data from you directly rather than trying to get anonymized aggregated data. Yes, David.
I was extremely pleased that when you started out talking about going down to Boston or somewhere.
Yeah.
And because I see a very common issues with people in QI is that they do a pre-measurement, post-measurement, and then they draw a line between the two, and then they conclude, right? Whereas the way that you seriously analyze data is very, very important. And two comments. One is that you had already quite a few EMR that was part of it. And then you have the other one that you have to work on, your own work. I would suggest that there is a power in terms of statistics, sampling. What you have may be all you ever need, really. You do have to compare some samples and to make sure that you actually have representative samples. And secondly is that the idea of measuring surrogates, it's very common because it's sort of, that's what you have in most people's EMR. You measure surrogate outcome rather than true outcome. And you have not shown anything in terms of the major elephant in the room is your healthy behavior section we're not even measuring those.
Mhm.
So there's still a lot of work to be done to help, e-form to capture healthy behavior, whatever they are, right? In a smaller sample, but good representative sample, but really focus your energy on that, rather than sometimes the provincial government may give you funding based on how big is your data set. I think you have to convince them that no, we're actually producing an analytically solid report, and we're very innovative in looking at all the underserviced areas.
Thank you. Yeah, so for those who didn't hear, that we might actually have enough data for the population level, but we want the individuals also to have the benefit of each viewer, so that's where we're continuing our engagement to enroll more people. And yes, it's all about sampling, and proxy measures really help. I think that's my time.
That is your time. I'm
Yeah,
sorry, I have
thank
to
you.
cut you off. We have other presenters.
Thank you.